a small group today, and it is, let's see what the time is. It's 6:03. I just admitted one more person. Let's see if they make it through. So here's what we were thinking. If we're a small group and we still want to run this, we would love to continue running it with everybody's, with the presenters, of course, approval. And then I'd like to hopefully schedule it again for the fall, because we're hearing that we're approaching holidays and summer and vacations. And Boston just had a big concert in Foxborough. So we don't know, usually we get 20 people for these sessions. This time we have 6, and I just admitted someone, but I don't see them. So what does the group think? And I'll throw the ball back at you, Chris and Barb. Do you want
to? So I do see one other person. I see Jim Sullivan there, if you can't see them, Jordan, I just wanted to point that out.
Oh, okay. Oh, now I see him. It just showed up on my screen. Hi, Jim. Jim, we're a small group today, and we were introducing each other. Feel free to introduce yourself.
Hi, my name is Jim Sullivan. I'm a sole practitioner. I just have an interest in homeless shelter, because you can't avoid it, especially if you're downtown Boston and wondering what these individuals who have lives do for the night.
Thank you, Jim. So this is being recorded, and should we go through it, presenters?
Well, I would just say I'd be glad to do a presentation in the future if there's for whatever reason there are sort of more people available on a date in the future, and I would also be glad to do it now in addition to that, or we could just adjourn for the future presentation. But I think I would leave that to the group, and as to the consensus of those who are here as to whether we do it only in the future or do it now and another time as well. If you agree, Barb.
No, I agree. And I was just going to say, it's an hour of your time. If you have a chance to see in the future and want to do that, I think that's fine. So whatever the group decides on, we're happy to go with.
So I'm gonna leave it to the group. Greta and Jim, we can go through it. We would love to go through it. It's a great topic and great presentation, because you signed in and took the time to do so. And then we'll repeat it in the future as well. Does that work with everybody?
I'd love to hear the presentation. It's very interesting to me.
Okay.
But I understand. I'm in the same boat, waiting for abstracts to come in for my symposium. And at the moment there aren't a lot. So we've extended the deadline. It's kind of like you want lots of interest. But maybe this could be a dress rehearsal. But this was good. I don't know. Really, the speakers and their time.
Okay. Well, why don't we go through it then, and then we'll repeat in the future and maybe in the fall, Chris and Barb. Okay.
Yeah, let's do that.
Whoa. Well, welcome to the 6th roundtable. Now that we introduce ourselves, I'm passionate about the topic because my last job at a big firm was next to a shelter, and I was not aware of the issue, honestly, but I saw them lining up in the morning and in the afternoon going in and out. And that's where, started to think that we need as architects to be more aware of what's going on. And this is something I found online. And it's about the homeless population and their unique characteristics, because they're not typical patient and typical, you know, children or families that we all are aware of. And if you've worked on a healthcare project, you know what's needed, or the programming or the circulation or the planning or what have you. So this is very unique, and that's what sort of inspired reaching out to folks with us today. And to introduce them, we have Chris Scoville from MASS Design Group, who worked closely with Barb Gillies. Sorry, am I saying it right, Barbara?
It's Giles or Giles. I answer to both.
Oh, Giles. And she is the COO of the Boston Health Program for the Homeless. So welcome and thank you for your time.
Here, I'll unmute. Unmuting helps. I'm Chris Scoville, architect with MASS Design Group. And I'm going to be saying next quite a bit as we move through a lot of these slides. Yes, thank you. So about 13 years ago, I spent 2 years renovating a house in JP, and my wife eventually wondered if I was ever going to have a real job again. So I had to go get one, and I just landed by happenstance with a small group of folks at that point who were just finishing up the construction of Butaro District Hospital in Rwanda next. And that was a project for Partners in Health. And Partners in Health sort of became a mentor to our organization and an source of inspiration. And we've come to understand our mission is to research, build, and advocate for architecture that promotes justice and human dignity. Next. And when I first started working for MASS, in fact was fiscally sponsored by Partners in Health. I got my paycheck for almost 1.5 years from PIH. And there are other organizations that PIH has sponsored. And then MASS became independent of PIH, but nevertheless maintained a strong relationship. And right at its genesis with this hospital, which was built for PIH and for Paul Farmer, who was very directly involved, and also for the Ministry of Health in Rwanda, that project really defined MASS's values, and it also defined, sort of exemplified what came to be true, and that is that many of our projects have been opportunities to work with really extraordinary organizations and with inspiring individuals. And so the architects who work at MASS are really privileged to sort of serve many, many folks who serve others. Next slide. Thank you. So in that sense, yeah, we help organizations amplify their missions, which is our mission next. And so I quickly moved on at MASS very quickly to work in Haiti. I worked on a cholera treatment center there in Port-au-Prince. Next. Next slide. A cholera treatment center right on the outskirts of one of Port-au-Prince's difficult neighborhoods. I worked on a tuberculosis hospital in Port-au-Prince as well for Gesquio. Next slide, please. And the TB hospital sort of has this sort of a lot of the resources of the design and the construction are devoted to the interior courtyard as a way to encourage these patients who have a very highly communicable disease to stay voluntarily in this ward for even months at a time. They could go of their own free will, but run the risk of contaminating friends and family. So in order to incentivize their staying there, we created a sort of a nice space for them. Next slide. So MASS, since those early days, has grown to be quite a large organization of 200 people with various design and engineering skills, as well as writers and filmmakers, researchers from all over the globe. Next. And yeah, we have offices now in sort of many cities, well, a few cities, and large team members and individuals in other locations than just these main offices. Next. And that original project for the hospital in Rwanda grew to be a kind of community through this sort of process we came to call catalytic infrastructure, where you build one large piece of infrastructure and it catalyzes growth in the healthcare sector, and then in other enterprises that support the healthcare sector in the area. And next slide, and you can run through these quickly. There's housing for doctors. Next, there's a cancer center, a rural cancer center, and sort of oncology support center for housing. And then this University of Global Health Equity, which was built for Partners in Health. So that's all. Now I'll stop here for a minute. These are the Nyarugenge Hospital and the Munini Hospital are now elsewhere in Rwanda. These are projects I worked on with my colleagues in our Kigali office. Next slide. And then more recently, MASS, based out of our Kigali office, did this Center for Diane Fossey's organization that was named for Ellen DeGeneres. Ellen DeGeneres' wife, Portia, gave her the birthday present of this institution, which is quite a nice birthday present. And next slide. And also in Rwanda, there's a large Institute for Conservation Agriculture to teach sustainable farming practices in what is a very, very hilly country, which has a fairly dense population. Next slide. And this is that same project done with a lot of very local materials, which is a kind of practice and use of materials that MASS sort of values in all its work. Next slide. And then sort of more locally back at home now, the US team has sort of grown to match or the sort of what has been the much larger team overseas. And here in the US now, we have various entities within our organization that address issues such as prison reform, sustainable agricultural practices, memorialization and public memory, and there's a couple of other specialties within MASS Design Group that we call design labs. Next slide.
Yeah, I know there you
Oh,
go. My mouse is sometimes
so
it's delayed.
We have a large number of partner organizations internationally, but in the US, you see some of them here. Some of these you'll recognize, King Boston and King's Chapel, and in the lower right, not least of all, is Boston Healthcare for the Homeless program, of course. Next slide. Locally in the US, a really big project of ours was for the Equal Justice Initiative, Brian Stevenson's organization. Again, an extraordinary mentor to our organization. And we did a memorial to victims of lynching, which is in Montgomery, Alabama, which got some attention. Next slide. Yeah, and this is that. This has been published a bit, and You may have seen it. Next slide. And then, but also we're starting to do some healthcare work in the United States, of course. A family health center in McKinney, Texas, next. And very locally in Brighton, sort of well underway into construction is J.J. Carroll. Exterior finishes are being put up there. This is a housing project we're doing. In next slide.
Is that solar I see on the roofs?
Yes, and I think it's actually going to happen. It hasn't been VE'd out. This is a very nice rendering. So fingers crossed there will be solar up there.
That's nice.
We actually are doing quite a bit of our housing team is very busy now in Boston, and we're sort of getting going on more and more significant projects with housing. Yeah, and please feel free to interrupt if you have questions. I'm grateful for that, in fact. And then the last 2.5 years of my life, believe it or not, was spent on all of the stonework you see here for the Embrace Memorial, which, you know, just personally, and I think the whole office is really heartened to see being embraced and turned by the city. All of the values of the kings, which were for, of course, justice, equity, peace, labor, have been sort of reflected in the kind of gatherings that have taken place here. There was a large Quaker vigil here for peace. There was a gathering of the labor movement here. Of course, memorializations for Mel King and for Tyree Nichols, the skateboarder who was killed so brutally. So this has become a real locus for that kind of public sentiment and gathering, which is just incredibly moving and heartening for all of us who worked on it. Next slide. And with that, I think bringing us close to home, right back to Boston, I will turn it over to Barb, who COO of Boston Healthcare for the Homeless program.
Thanks, Chris. Hi, everybody there. Oh my gosh, my talk's going to sound like so small compared to Chris's global presence, but we're just really proud to partner with Chris. And we have one slide of our recent work together. But I think the common threads that I hear through your work, Chris, are some of them are like social justice, right?
That's absolutely.
Yeah. So, you know, here we are, Boston Healthcare for the Homeless program, and we're serving folks that different things, broken things in society have brought them to this moment in time. They're in front of us. So, you know, racism, broken, you know, educational system and redlining and other types of things that, you know, inequities in government and my gosh, like when I look at Boston now, where Pine Street Inn is, the gentrification that has happened in that area, these things are all, and the loss of the single occupancy places for people to live in, all of these things contribute to the person that we see in front of us. And so we realize that there is a person who's suffering in front of us. We have a trauma-informed lens, and we do realize that like these bigger flaws in society contribute to this moment in time of when we meet people. And so we are, next slide, thanks. I'm gonna have a mouthful on this slide here. So we are a federally funded community health center, and we're unique in a couple ways that I'm so glad to have this chance to share with you guys. We were founded in 1985 when Jim O'Connor, our founding doctor and a psychiatrist, started doing street medicine down at the Garden in downtown Boston and other areas. And since that time, I'll talk a little bit more about Jim on another slide, but since that time, we have grown to now have over 600 staff members. We are serving 10 to 11,000 individuals and families a year. And what we do is we focus on healthcare when we think about all these contributing factors to homelessness and what's happening in the globally too, Chris, not just narrowing it down here. What we do is we focus on healthcare, and we are mission-based, and our mission statement includes things like access. So we try to break down access to care, and that will help you understand where we are in some of our places that we're at, and address barriers to care. And then also equity is a big part of what we do now. And we realize that inequity in different systems has led to where we are, and we've incorporated a lot of equity into the work that we do now. So our program is team-based, and we have a lot of different branches, but we actually all work together in an integrated way. And we found that it really does take a team to meet the complex needs of the patient who's before us. Our patients that we find in front of us are very complex. They have acute physical ailments that usually brings them to us, and they usually have chronic conditions that they weren't, because of the conditions of their life and just struggling for food and shelter, they weren't able to address other health conditions. So now they've become chronic and acute. Over 2/3 of the patients we serve have behavioral health issues, most of them long-term and untreated. And now we've known for years that this other piece of the onion of the person that we're serving is addictions. And so we really have this complex person before us. And how do we deliver care? How do we break down barriers and access so we can reach people? If you'll think about the very early days of healthcare for the homeless, it happened outside of a big hospital in New York City, St. Vincent's Hospital, when one of the doctors was walking into the ER where he worked, and he had to step over a homeless person who was lying on the ground. And he just thought, like, what is the disconnect here? Why is this person feet away from this wonderful medical health center, and yet we're not able to reach them? So that really was like the genesis of healthcare for the homeless. In 1985, there was a Robert Wood Johnson grant, and there were several of them across the country, a little over 10. And that was the genesis of the funding of figuring out what were the healthcare needs in different cities across the country. And Boston was one of them. So Boston was a recipient of one of these grants. Through the years, we've evolved to find that to meet the needs of folks, we have to expand and grow in different areas. And being a nonprofit medical healthcare, we're able to flex quickly and pivot to needs of people. And we'll go through how we've been able to do that over the years. But our program includes adult and child primary care, public health interventions in, we're fleet of foot. We're able to pivot quickly and go to the Pine Street Inn when there was an outbreak in meningitis, and just screen everybody and vaccinate everybody and do everything in just a short amount of times, because we have lots of nurses in healthcare, and we're able to do something like that, whereas a larger entity probably doesn't have that arm of ability and flexibility for them to provide care so quickly. We have street medicine, and that's how we started. I'll talk about Jim a little bit more. We have mental health services, addiction services. Our addiction services has grown immensely. Back in 2013, we did a morbid and mortality study internally to see what are our patients dying of. And so our first morbidity and mortality study back in 2008 showed that most of our patients were dying of HIV. And if you think back to the times, that was before the cocktail was invented and things. And then after that, cancer, hypertension, things like that. And then when we redid this study in 2013, for the first time, we saw that just eking out cardiac diseases was that patients were dying of unintended overdose, unintended overdose deaths. And we were stunned by this, like, what is going on? And what we did was we had to change our whole program and pivot and shift our care and our education and our way that we were delivering medicine to expand our addiction services to meet the needs of what was happening. So we've known and seen that opioid crisis rearing its ugly head since 2013. Transgender health services, we have a unique, besides the community health center clinics that we have that we'll talk about off to the right-hand side, we also have something called medical respite care. We'll show you some slides and talk about that a little bit. We have dental care, and we have case management. On the right, you can see how spread out across Boston we are. And this part of this is because we are breaking down barriers to care, and we are concerned about access. And we found that some of the, well, a lot of people weren't, because of their hierarchy of needs, weren't able to access medical care. Maybe there's transportation issues, maybe there's other impending things such as getting in line for a shelter bed. So what we found is that if we go to patients and break down the barriers of access and other things, that patients will access care that way. So we're located now, we have a freestanding building and some freestanding clinics, but we actually are in day programs. Credit, I'm thinking of you there, community day programs. We are in shelters. We are in soup kitchens. We are any place where the homeless group, homeless people are, and we want to reach and provide healthcare. That's where we go to. And because of that, we have some unique architectural needs. Some of the sites that we're in were guests there. And so we're given a space and we do healthcare from that space. It might only be a one-room, one-room clinic, but that's what we have to do. We adapt to the area that we have. And if we can't change the space, we will alter our ways and try to deliver the highest quality healthcare that we can in that site. So lots of challenges architecturally for us, and lots of changes ongoing all the time. Next slide. Thanks. And feel free to ask any questions. I'm really giving you a lot all at once. This little collage is like showing where our patients live and where they are. And if you look in the right upper up top, you see one of our nurses. She's gone under a bridge to deliver care and meet with folks who are living under the bridges in our city. There's tents all over. There's people where you sometimes are at the train stations or the airport, other places like that. The bunk bed systems that you see down on the lower left-hand corner, these are shelter beds from the Long Island shelter that used to be out on the outer islands of Boston. I'm not sure if any of you are familiar with that, that we had to, the bridge to the Long Island shelter had to come down. And so the shelter moved. But this is what it looks like, double beds. Pine Street looked very similar to this, but since COVID, they've had to get rid of a lot of bunk beds and move beds apart more so that people have a 6-foot radius and things. The infection control measures have now made the shelters look, especially the larger shelters, look a little different, which is a good.
Barb, could I jump in for one thought?
Sure.
And that is that I think what we're looking at here are the places where you deliver services.
Right.
This isn't just where you find, this is where you find homeless folks, but it's also where you give healthcare. And in fact, where you are licensed to give healthcare and where you get reimbursed to give healthcare. And we're not looking at hospitals here. We're not looking at clinics designed by fancy architects with big budgets. And so this kind of challenges all of us who are used to thinking that healthcare design involves this very planful, forward-thinking, very, very expensive infrastructural investment. For you, It often does not.
Yeah. And, Chris, thanks for speaking about our models. It really does take a village for us to do what we do. And one of the ways that, was in order for us to build, as Chris said, we have to be licensed. And so we have had to work with DPH and with other people in the state and the city to be allowed to, first of all, be present in different areas. We're guests in many of these sites, and then to be able to bring the services right to people. So it really is some unique settings that we're in. And for the architects, I think another person made up this batch of slides for me, but if you look at the loss of dignity in the bathrooms, this is still there. This is at the Southampton shelter right now. This isn't an older slide from, from the Long Island. This is what the toilets look like in a present day shelter. So we did want to share that with you. Next slide. Okay. I'm sure many of you have heard about MASS and CAS and the epidemic, the ongoing epidemic, opioid epidemic that's occurring, and folks are congregating together down there. We are present in a big way on this street, Atkinson Street, and the surrounding area because the healthcare needs are there. We are over 20 full-time equivalents of healthcare workers there. We have doctors, we have psychiatrists, we have mental health workers, we have nurses, we have harm reduction specialists, and we work with many entities down the street, but our focus is healthcare. People are using the situation of having to use medications have increased needs and brought some consequences with them. So in the old days, you know, when we used to take care of veterans that came out from Vietnam, they would use heroin a couple times a day, and it was a very controlled situation. With the introduction of fentanyl now, it's a quick onset, quick into withdrawal, onset, you know, high withdrawal, high withdrawals. The wave has changed, and people are having to use much more frequently every day, sometimes 6, 7, 8 times a day. And with that came having to use more syringes. And there was a lot of sharing of syringes. So concurrent with the opioid epidemic down on Atkinson and MASS and Cass has been well over 125, 150 new cases, a cluster of HIV. And so our staff is down there doing medications to prevent spread of HIV. People have been exposed. We're using exposed medications. The new cases we're actually treating with the medications. And then we do a lot of overdose responses, anywhere from 0 to 10 overdose responses a day our staff does on this street. And lots of wound care. I don't know if any of you have heard of this latest additive that is getting into the drug supply, but it's called xylazine. Chris, you're shaking your head. Yes. So xylazine is actually a sedative that is used in veterinary sciences for operations and things like that. Well, now it's being cut into the fentanyl. And what it causes is these really striking wounds. And it's not just at the injection site. It's like you might inject in your arm and then you have this huge wound on your leg. And I'm talking layers and layers of exposed skin. So lots of healthcare needs and wound care down there. And that's kind of what's happening on the street here and why we're there and participating.
And
Next.
and you need,
Yeah.
and Barb, you need to do that all in the open, right? Like there isn't, I don't know, like enclosed in all sort of weathers too.
Right.
I mean, it's an outdoor.
Yeah,
Basically,
365 days a week, you're right. And so on this street of Atkinson in the surrounding area, the Southampton shelter is there. And within that Southampton shelter, which is, you know, sometimes up to 500 men a night, we do have a licensed clinic in there. And then there is also a building by the Boston Public Health Commission called the Engagement Center. And we do have a small 2-room clinic in there that, it's like a revolving door. The needs are so great on this street that we are able to bring patients in for some privacy in these 2 areas, but most of the work happens on the street. People have backpacks. Our staff are well marked in blue, you know, jerseys with yellow tape and things like that so that we can identify ourselves. But you can see the engagement center on the left-hand side. That blue slanted roof is under construction, the engagement center. It's now open and functioning.
That's great. At least there is an option to be undercover.
Right. And look, if you look at the building behind the engagement center, that's the House of Corrections. And it's kind of like people are just discharged to the street and just discharged right onto Atkinson. Okay, so now this is Jim O'Connell. He's our founding doctor who answered the call to the Robert Wood Johnson grant. He was going to do this, serve as a doctor to figure out what were the needs for the homeless in Boston. And he's still doing it 38 years later. Jim has a team that is called the Street Team. So Jim and a cohort, they do most of their work down in the area of the Boston Common and MGH Hospital, and they're actually licensed by DPH as a clinic. So this street team that Jim leads is a licensed clinic so that we can bill and provide care. Some of it is right on the streets, some of it's in the park. It's a unique model. And Jim has been able to make inroads with folks and really figure out how to make a trusting relationship so that we can have that as our basis of care and then move forward with people after they've come to trust us.
Yeah, and I would just note that Jim, aside from like the extraordinary person who does this extraordinary work, is also hilarious and a bit of a cynic. And he notes to me that he had the terrible misfortune of being in the same medical school class as Paul Farmer. So he jokes that he sort of sees himself as a bit of a failure because, you know, Paul Farmer was his classmate. But of course, that's absurd. What he has done and what the other people such as Barb and so many others at Boston Healthcare for the Homeless Program do is extraordinary. And they are sort of very much like Paul Farmer in that they are these amazing clients who serve people and who designers, not just MASS, but other architects as well, have the kind of privilege to serve and support and learn from.
Thank you, Chris. And it's a two-way street. We are so grateful for our architects that we've met along the way and have helped us and really spent the time to figure out what the needs of the patients are and how to meet them with an architectural eye. So it's a two-way street. Thank you. This building here is at 780 Albany Street. We're across from the Boston Medical Center, ER. We're also near two of the largest methadone clinics. Right next to us is the Boston Public Health Commission's syringe exchange building, and many other entities are nearby that have also offer services. But this is our main building. We used to be in a couple different buildings, and about 15 years ago, we were able to obtain for $1 this old morgue. It served as the city morgue. There's still an underground tunnel from BMC to our basement for when patients would expire. At BMC, they would come underground and over to the morgue, and other architectural details that are left from that time. But this main building houses our administration on one wing, and on the second, third, and fourth is where our medical respite is. And a medical respite this is the first of the medical respite in the country. This is a place where people who are experiencing homelessness, maybe they're in a shelter, maybe they're on the street, maybe they're in a car, they have a medical issue, maybe they're in the hospital for it, it's time for discharge. They may have had open heart surgery. They may have a broken leg and steel rods in it, and they're not able yet to return to the street. They're not able to return to a shelter. And so we think of this as like a bridging place for people to be. So we bridge between the hospitals and we onto the street and the shelter. And so people come here for medical care, and we have nurses 24/7. We have full teams of doctors, psychiatrists, behavioral health, case managers, etc. And our length of stay for people to stay is, it used to be about 14 days was the average, and it's increased a little bit since COVID. When we were thinking about what to put in this building, we'll talk about dental and a couple other things, but we went and we talked to patients that we were serving and said, what would you like in this building? And then we added those things to this building. So the medical respite, our largest clinic is here that sees over 200 patients a day, our ambulatory clinic. A pharmacy is in here. Our patients told us that they weren't able to get their medications because there was a 3-hour or more wait at BMC to get their medications without a copay. And they couldn't wait that long because you have to stand in a line to get your shelter bed. You have to stand in line to get your meal. And so that was their priority. And so they weren't picking up their prescription. So we built a pharmacy, and our waiting time is 25 minutes. So we were able to really help people connect with their medications. You'll notice that atrium up top, we'll talk about that. That's in the middle of the U shape. There's a glass enclosure that serves a lot of functions for us. So we can talk about that in a minute. Thank you. So here our medical respite looks on first glance almost like a med surge in a hospital. But we have congregate rooms. We do have like 1 or 2 isolation rooms that we've had to have for people with, say, tuberculosis or someone that needs isolation. But most of our rooms are 2, 4, 6 rooms together, and people have shared that they wanted to be in that congregate setting. They're used to sleeping with others. They're used to being around others. And that was the design that was the input that led to this design. Some folks have been with us for the 37 years that Jim has been doing this, and others, and maybe they don't want to die in a nursing home. Maybe they are immigrants that don't have access to healthcare, and so it's their end of life. We also can do end of life here for that group of folks. Even something as easy, think about all of us here. When you have to have a colonoscopy, you get the prep, you do it in the privacy of your home, and then your person takes you to the hospital and brings you back home again. And this is impossible for, many people staying in congregate livings. And so something as easy as a colonoscopy, we really help with quality measures and preventive health measures by bringing people in the night before, helping them with that prep, getting them to the, colonoscopy suite and back again. So that's the kind of things that we're able to do.
Mm-hmm. And
The
Barb, I would
glass-
say,
Yeah, okay.
I would just note about, I guess
Are we doing time-wise?
there we go. In
Chris,
the last slide, I think two things come to mind which have sort of architectural implications for the medical respite in the last slide. And one is, as I understand, in order to bill for services, your medical respite patients are outpatients. And so that requires, even though, and this is a bit of wordsmith, but this is the very, very creative way that you folks sort of structured the kind of delivery of services, but also the planning of the floors here. So in a standard hospital ward, of course, medications would be delivered to a patient at their room, at their bedside. In your medical respite facility, patients have to leave their room and get their medication at their nursing station, which might be what we see on the right here, if I understand correctly.
Yeah.
And so this leads to very sort of unique kind of planning arrangements in order to support your funding model that are quite different from what you'd see in a kind of more standard healthcare environment. And then the other thing that I've come to understand from working with you in this building is that much of the building was built for administrative offices with a kind of standard double-loaded corridor that has, of course, when you renovated it, become sort of very intensively used clinical space for exam rooms and nursing stations with oversight over those exam rooms. And that dimension, which is sort of not mutable, and that structural bay is not supportive of an optimal plan arrangement for current plant care delivery. And so whereas an institution like MGH or the Brigham would have some time ago realized that, this is not sustainable for them and that they need to kind of move their clinical care into a bigger floor plate where they can optimize those kinds of services. The healthcare for the homeless program is left kind of, as you described earlier, making do with, as well as they can with what they have to deliver those services within this floor plate, which is what they're living within, and delivering extraordinary care within, but it may not be optimal by some other sort of perspectives.
Yeah. And the glass enclosure that you see is called our atrium. And that's a space that when we were building this building, Jim O'Connell was very adamant that people had a place to go to where they felt they could relax and have community. But we have had to flex this space for so many different things over the years. When that bridge broke down, was dismantled at Long Island, this room here in the atrium, we were housing a women's shelter for 9 months. We had 47 homeless women. We'd set up cots at night. They'd sleep overnight. In the morning, we'd dismantle the cots and they'd go on their way. And then same thing for 9 months. This was a shelter. It also has served many other functions. On Sundays, there's religious services here. We've hosted dignitaries here for press conferences. We've had to now hold our behavioral health groups there because as we're running out of space in the building, this is our big open flex space, and we've had to do so many things with this area. I do want to point out, though, too, this outside deck is a smoking deck. Unfortunately, 73% of our patients smoke cigarettes, and we try our darnest with many interventions to lower that number. But if we didn't have a place for patients to smoke, I'm not sure we'd have many people in this medical respite called the Barbara McGinnis House. Yeah, thanks, Jim.
I just want to add, Barb, to that space. When I toured the building, everywhere when we look at typology related to the homeless, whether it's housing, whether it's a day center, whether even where they hang out during the day, like in libraries, there is a community of these folks who network within themselves. And in this particular model that you have, it's very uncommon. You don't find this in a hospital where there's this big open space that you can do whatever you want to do with it to your need to serve this population. So I loved it, and I found it really unique and inspiring in a way.
Yeah. Many folks come now that COVID has ended and, well, has gone down. We can resume movie nights and bingo and other kinds of entertainment there too. So it's really been a special space. AA meetings there. It's so multi-use for our patients. I think because of time, I'm going to just go quickly through these next slides. This is a picture of what Chris was referring to, is that at the end of our hall of the medical respite are 4 exam rooms on the 2 floors each. And that's for our billing model and also our model of care. We can bill for 3 shifts of nursing a day, and then also the provider visit. So the providers have to have an exam room. So each team, 4 teams on a floor, has an exam room, and patients are seen every day by a provider, 3 nurses, and then also room and board. So that's the model. That's Barbara McGinnis House again. Next slide. Here is one of our doctors providing care down in our BMC clinic, which is which I refer to as the largest clinic. And our clinic downstairs is also our area where we have our many ways of giving medication-assisted treatment for opioid addiction. And so it's really a busy place. And this is behavioral health provider speaking to one of our clients within our area. This area here is very interesting. It's called Spot. I know you know this place well. We also had, when we realized the opioid epidemic was expanding, and it was, due to our location and other places, I'm sure where all of you are, you're seeing more and more people on the streets and nodding and opioid use and fear of overdose. And so what we have done is we've opened this one room. It used to be a conference room. Well, we've changed it into a room now where patients can come after they've used sedating substances. Maybe the police will bring them, maybe EMS will bring them, maybe friends will bring them, maybe they'll present by themselves because they're worried about overdosing because they heard their friend overdose with the same drug supply. And so people come in and they're welcomed warmly. We put monitors on them and we monitor their blood pressure, their breathing. We make sure that there's not, that if they start sliding into an overdose situation, we can intervene and safely. And so people come and go all day. It's one of those things like, if you build it, they will come. And it has really just saved a lot of lives, formed a lot of relationships. And we have astounding numbers from this of people entering detoxes, having some sustained sobriety, getting into treatment programs, reconnecting with families, starting on the medication-assisted treatment. So it's really been a wonderful program for us. And if we had more space, we would offer even more beds, but we're limited in this. So that's our space for observation treatment. Dental, I was referring to dental. It's one-stop shopping in this building at 780 Albany. One of the things that people shared with us when we were building this building was that up to 90% of the people that we serve experience dental pain. And it's really came from a life of poverty and not being able to address and get dental care that was needed when they were younger. And so now they're presenting with lots of cavities and other kinds of things. So we have a very active 6 suites now, or operatories, I guess you call them, to deliver like top-notch dental care to folks. So that's really interesting. We have an immigrant health client, base that are not eligible for healthcare insurance. And so we have a group that come up and just services directed right towards this group of people called our Oasis clinics. And that's going to restart after COVID finally on Sundays at 780 Albany Street. Next. Women's health. We are in many places where women are, especially during the day. So we're in women's shelter at Woods Mullen. We're over at Rosie's place. We're at the women's lunch place. We're at the St. Anthony Shrine. And so our providers do all sorts of healthcare, preventive, birth control, other things like this. Although that was a gentleman there, but I'm using that slide for women's healthcare. This is St. Francis House Clinic, and that's one of the few places we have left where we do direct foot care. And if you think about being homeless and on your feet all day and out in the rain and the snow and all over, foot care is really needed for this group. Dry socks are needed for this group. And it really is a way to show dignity and engage people into care. When people come in, we also take their blood pressure and maybe check their blood sugar. And so it's an opening and a way for us to form relationships with people and move them along and connect them to services. This is one of our doctors in New England Center and Home for Veterans. You might think people would be at the VA, but there's lots of people who are veterans, but they're not eligible for service from the VA, or they have acute care needs and they can't wait for the waiting times at the Veterans Hospital and others. So this is a very active clinic for us, the Veterans Shelter. Thanks. Next one. Getting toward the end. Oh, look at this beautiful space, Chris. This is our family care clinic. This is in the Horizons that Chris designed. And this is a beautiful family clinic. And this is a continuity clinic for us. For years, the state, we're a right to shelter state. When families were showing up in huge numbers, people were placed in hotels, people were placed in other shelters. But when we were going and delivering services right to them, but then after they were housed or moved into another place, they needed a continuity clinic. How could their children who missed their vaccines get into the schools where they moved and other healthcare needs? So we're fortunate enough to have Chris's help and build that beautiful clinic for the family team. Chris is going to talk a little bit more about the tent medicine that he helped us with for COVID.
Yes, and sorry we're running out of time, but we can go through it. Chris, you want to go ahead?
Mm-hmm.
Thank you, Barb. That was amazing.
That was a lot of spewing. I'm sorry. It was a lot to say in a small amount of time. Thank you. Go ahead, Chris.
Chris, you muted.
Two, I think. Hi, I don't know if you can you hear me? I'm trying to get more bandwidth in my household.
Yeah, we can hear you.
Why don't I speak to this later, Barbara? Please go ahead and I'll pick it up in just 2 slides.
Oh, sure. I think the next 2 slides just show that here we're at the BCEC, the Boston Convention Center. The governor asked us to run 500 beds for the homeless who have been exposed or are suffering from COVID during the height of the COVID crisis. On the other side of us was 500 beds of MGH. So it was really a great experience for us, and we were able to provide care and support for homeless people and also the poor and multi-generational families and things like that that needed a place to isolate. And I'll be quick next. These are just 2 quick pictures of the first vaccine that arrived, and then the first patient that we could, a shelter patient giving at Southampton Shelter. a vaccine, and we've been very successful because of our relationships that are established to help people, get the vaccination help that they needed. Okay, thanks.
Chris, are you still with us? You kind of frozen. Well, I'm not sure if Chris can rejoin or he is just, let me see if I can contact him through the chat. Oh, he's gone. Okay. This is very unconventional roundtable format and ending. However, I mean, it's amazing from what we heard today. And please, we have like a minute or so. I want to hear your thoughts if you have any questions. And thank you, Barb. And thank you, Chris, if you can still hear us somewhere. But anybody would like to comment, what we're thinking is packaging this again and do another run at another time and maybe in another forum or format. Here is Chris coming in. I'm admitting him.
So if I just have found this, well, I wanted Chris to hear this. One of the most moving presentations that I've been to in a long time. Of course,
Hi, I don't know. Can you hear me now?
Yes, we can. And thank God you're back.
Hello?
We can hear you.
So,
Chris,
Okay, so I'm having some little bandwidth issue in my household, and I think my 2 teenage boys are now off the internet. But MASS did a few projects has done 3 or 4 projects with Boston Healthcare for the Homeless program over the years at Barbara McGinnis House. We did an office for their finance department and near Barbara McGinnis House. More recently, we did a family practice clinic, which who may have dropped off, I'm not sure. Helped advise us on. And I'll move quickly through this in the next slide. The family practice clinic at 1785 Columbus Avenue was a way for Boston Healthcare Homeless Program to consolidate care they were giving at a few different locations into one location. And it's very conveniently located in the same building as Horizons for Homeless Children that provides daycare services to children of families without housing. Next slide. And this clinic, which has an excellent view of the White Rock Brewery sign, next slide, is on the 2nd floor of this new building. And it's the program is clinical in blue, the public area, waiting, reception, and gray, and administration in the yellow on the left. And it's like a lot of healthcare planning in that, the circulation, the separation of circulation between of the public and the administrative and clinical staff is important. And we sort of accommodate in this plan with this sort of this desk drop down area, which also is a circulation route for the staff between the 2 sides around the waiting area. This plan, in planning this, we were required to address new DPH regulations, then new ones regarding what's called POS, patients of size, which required us to have very wide doors, space for larger wheelchairs, provision of services in exam rooms and other counseling rooms and toilet rooms for larger patients. And that was something I helped sort of did a kind of peer review with us on. Next slide. And this these slides here have not been approved by the Mass Design Group graphics department. I did them myself, so apologies. But these were at or near completion, you know, of this sort of waiting area. And one of our goals here was to create a kind of patient experience which had the kind of dignity and the kind of quality of experience that anyone would expect going to a clinic, so that, you know, these folks understood that when they were going here, the environment reflected the kind of level of quality of care that they could anticipate when they got in the exam rooms, and that they sort of had confidence about what BHCHP was providing, which is really extraordinary service. And so, next slide, please. So sometimes I've joked that the reason that there are no TV shows about architects is because there are no architectural emergencies, whereas there are TV shows about lawyers and doctors, because all kinds of exciting things happen there. But at the beginning of COVID, I had as close to an architectural emergency as I ever thought might happen. And Jesse Gata, who was the chief medical officer at the time at BHCHP, called me at 8:56 in the morning one day, completely out of the blue. I'm not even sure I'd spoken to Jesse before this. And she said they were going to be putting up a tent clinic for COVID patients. This was in the very early days of COVID. And I hustled downtown and I met her at 10 o'clock, an hour later, and with a couple of others at BHCHP HQ. And then, you know, we whiteboarded, and I looked at a plan she already had, and we whiteboarded ideas about patient flow, about air circulation, about doffing and donning, and how to achieve that. And then at 11:30, I met with the contractor. So it's the fastest project I've ever done. And it was quite amazing. Next slide, please. And that tent clinic, and Joshua Barokis, who is at Boston Medical Center, which is has a very close partnership with BHCHP, and it was working closely with Jesse Gata at the time, was also consulting on this. He's an infectious disease physician, and the resulting tent clinic sort of clearly showed how quickly it was put up, but it nevertheless provided really vital services in a very short period of time. And I think what's so interesting for me about this project is, you know, how we were all working on the fly, and not just working on the fly, but thinking on the fly. And as you'll recall, you know, during the early days of COVID, there wasn't the kind of clarity that we have now about what the disease was, even how it was transmitted. And for Mass Design, working with Mass Design Group, I sort of had been trained to understand that airflow was a very important issue in all clinical contexts. So I advocated very, very strongly for an airflow system that would isolate infected patients, not from one another, but also from their caregivers. And I was counseled at the time by a very senior physician at Harvard Medical School's infectious disease department that was not necessary, and that COVID was really transmitted through large droplets on surfaces. And I, in the end, happened to be right. But that's not because I knew more than this guy. This guy is way smarter than I am and knows more. It's because I just got lucky. And, you know, in fact, the thinking evolved. In fact, we came to understood that COVID could be aerosolized, if I understand the sort of technical definitions of these terms correctly, but that was not understood then. And so it just points to sort of how I think nimble one has to be, and perhaps humble one has to be in the fact of in the face of precise information when sort of working in these contexts. And next slide, please.
That's an amazing story, Chris, and I don't miss those days where we're having a guessing game going on.
Yeah, right. And so we did this planning, as I said, and we came up with a strategy for sort of doffing and donning, and I guess donning at the sort of low risk side of the ward, and then doffing, having passed through to the high risk side. Next slide. And yeah, this was really a kind of wonderful thing to be a part of. And at the time, all of us were thinking as architects, and I'm sure not just in my office, but as a profession and as a community, about how we can be helpful in this context. And I think for those of us who worked on this project, it was just really a gift to feel as if we could have some helpful purpose in the midst of this confusion and distress. For anyone to have a purpose is a way to to make sort of life meaningful within trauma. And so this was important, I suppose, in a personal and professional way in that respect. Next slide. And we ended up drawing up these plans, and we in fact created a set of guidelines, and you can kind of scroll through the next slides. And these guidelines we published as a white paper on our website and were distributed. And this has to do with how we might provide toilets and temporary power, and provide dignity and efficacy, because this was a kind of guiding set of principles for other communities that might be doing this, because as you will recall, this was there was this kind of nationwide concern about how are we going to handle COVID, not just for homeless populations, for others as well. And nobody knew how far this was going to go and where. And so we were sort of sending out these guidelines in the hope of contributing to a dialogue and helping others sort of move forward from the work we had done. And
Thank
I think
you.
that's
very nice.
I think those are my slides, and that's the extent of sort of the presentation at the moment, in this rough draft, as we've called it.
Greta, do you want to repeat what you were saying before Chris, when we lost Chris, one more time? I mean, this is really wonderful. And I know it's a small audience, but it's so rewarding. Go ahead, Greta.
No, I was thinking we were about to wrap up at that time. And I just find that both Barb and Chris, you have given such moving presentations. And I love the combination of sort of the beauty and elegance of the worldwide solutions to healthcare for people who are not, in disadvantaged situations, and then knowing the nuts and bolts of what's happening here in Massachusetts with the homeless population. And I just applaud you both for all the courage it takes to do all of those things. And I just wanted to say that as kind of a maybe less courageous person who has mostly always worked to try and support the courageous people in my work, writing specifications. I worked at Payette and Shepley Bullfinch and other places that did great stuff. But I like having that supporting role. I just wonder if when you redo this presentation in the fall, there would be time to think about how other members of the profession can be of help. I don't mean for you to answer that right now, but I think I would love, especially since now, well, I apologize, I had to leave. I have sort of family emergency going on. But
Okay. We-
hopefully I'll be more, have time to get involved. And I do, I have a church that would like to do something. We wanted to provide showers for homeless people because we find that we're right in the middle of Waltham, and we have a faucet on the outside of and a hose because we have to water plants and so on. And that homeless people were coming and washing themselves. And so we thought, well, what would be a more dignified? So there are little things that can be done. And anyway,
Thank
just,
you.
that's food for thought. I hope I can find ways of being involved.
Absolutely, absolutely. Chris and Barb, I can share Greta's contact with you if there are any opportunities for volunteering or helping or what have you, for sure. And we ran out of time, and I apologize. I and Jim, any comments, any final thoughts or questions to our
Sure.
presenters?
Yes, I appreciate greatly both Barb and Chris' presentation. And I guess I'd be interested in learning about the logistics of the tent medical center and what that entailed in terms of design, but also on a personal level. I live in West Roxbury, which is part of Boston proper. And with COVID, I've been working at home. So I got to know my neighborhood more intimately. And I was so just surprised at the number. There weren't a lot of homeless people, but I literally got to know one by name. And he's finally got his own place. But I was wondering on a personal level, how one can help someone that might be in distress, because I got to know him well enough that I concluded that it was mostly mental illness. Sometimes people on the outside prejudge someone, whether it's be drug abuse or alcohol abuse, etc. And but the mental health component seems so complicated and challenging to address. So what I guess I'm trying to get at is it's pretty amazing. I always wondered what that McGinnis Pavilion did, what would happen there. But I just wonder how, as architects, we can be more active in support, participating in this homeless problem. And I was wondering if the mobility, because as I said, the clinics that were located, they're not really close. We're in West Roxbury, closer to the suburbs. And I was wondering if there's any outreach for that. And then the only other comment was the book by Tracy Kidder, is that basically about the life of Dr. O'Connor in this whole system? I haven't read it yet, but it got a lot of press in the past.
Yeah, Jim, happy to answer that about the Tracy Kidder's book. There's such commonalities running through this whole talk with Chris, with you and partners and Tracy Kidder. But the book does follow the street team. So that's just one team, right? We're 30 licensed clinics, but the street team is a licensed clinic. And so Tracy Kidder came and followed Jim and the street team, who were mostly down at the Garden and downtown and MGH, and followed him for several years, and then wrote the book. So it does just concentrate on a small team, but we're much bigger than that too. Not so much out in West Roxbury. But we're happy to do needs assessments and connect people to resources. And we certainly are a rich resource from anyone experiencing homelessness with, medical, behavioral health, addiction services. Yeah.
And the other thing, the other thing I learned too was the individual has to want to enter the shelter. There was another episode where there was a woman who slept the night in an alcove entrance to a church. And, I asked her, I said, do you want to be helped or something like that? and I called the police to see if they could assist, in some way, but they said unless the individual of their own accord wants to go someplace, that they can't do anything. That is basically, that's how it works. If they don't want to help or get involved in the system. And the other thing I learned from Dino was that he had a resistance to even go to a shelter because the little possessions they have, they felt as if they would lose it by going into these shelters as well. So there were times, and I said, the good news is I believe he has some sort of housing, but he would literally sleep on a commuter rail station bench all night. And it was just hard to see.
Yeah, shelters are, for many people are not a great place. They're traumatized from situations that happened to them before.
Yeah.
They, it's a congregate living. There's just it's not for everyone. And some people will only come in when they're brought in the really cold weather, or, when it's really dangerous and risky for folks out there. And it's still, yeah. Go ahead.
You can't, I think you cannot, by law, you can't force somebody to take treatment or to go into a shelter unless, like you see them, they're dying or something. But different cities differ on that. Like in New York, the mayor, I think, of New York, or the governor of New York, decided that, and there's a whole argument about treatment first or care first or housing first. And he passed on a ruling that if you see a homeless person who is in danger to themselves or to others, like they're really struggling, then the city has the right to take them to a safe haven, whether it's a shelter needed or it's a hospital, and they'll be taken care of. I think some cities, they still can't do that. And that's a very tricky situation.
Okay, thank you. And one last thing for Chris was I would love to learn or hear more about the clinic in Haiti, because all we hear about is the chaos and the gangs and the instability of the government. I'm saying to myself, how do you build a clinic in that atmosphere?
We could not do the work we did now in Haiti. This work was done between 10 and 12 years ago. And it was extraordinarily difficult to get those buildings built, and required the kind of dedication and sort of relentless work and oversight that we were positioned to do as a nonprofit, but which I wouldn't think another architect could have done, just because of just through no fault of their own or their offices, of course, but just because of the way we were financially structured, we were able to build those buildings. Now, it would be impossible for us to do that work. We aren't doing any work in Haiti and haven't for many years. That was as unstable and difficult as it was then. That was a relatively stable window in Haiti's recent history.
Well, it would be interesting to get your take on Haiti, and I'm sorry to take more time, but get your take on Haiti, because the little I know about it has such a noble historical legacy as being the first independent Black nation in the Caribbean, and it's just, I don't understand how it's gotten to this place today.
I don't understand it either. I know quite a bit about it, but I don't fully understand it. My big takeaway as an architect from having done work in Haiti is that we built two buildings, significant, two-story hospital buildings. During the entire design process and the entire construction process for both of those buildings, not a single authority, municipal or federal, reviewed our drawings, looked at our drawings,
Oh my
asked
God.
about our drawings, or visited the building site.
Oh, wow.
No one. And we built those buildings to Florida hurricane standards and California earthquake standards because that was our value and we insisted upon it. And our client insisted upon it. But when the next earthquake hits near Port-au-Prince, the disaster will make the last one look small, because
Oh, wow.
since then there has been so much insubstantial construction on more and more precarious sites surrounding Port-au-Prince. And as an architect, I went to Haiti with a chip on my shoulder about authorities having jurisdiction and resenting how they made me do this and that. And when I left Haiti, I came to understand like how important they are. So that was my big takeaway as an architect from that work.
Wow. Thank you. You both do such great, rewarding work. You're contributing to a better society.
Thank you,
Well,
Jim.
And
Do you
I
have?
as well, because I think we should be clear, I has done a good deal of work with Boston Healthcare for the homeless program. And that wasn't made clear earlier, but it's important. And I hope you can join our next presentation and weigh in.
Aya, you want to say something? I'm sure 2 people know you and 2 people don't.
It's okay. No, Chris and Barb, it was a fantastic presentation, and I'm so glad to have joined it. And yeah, it definitely deserves a bigger audience. You know, it's hard to not be inspired by the work that Boston Healthcare for the Homeless does. You know, as architects, we're kind of trained to, you know, on more of a kind of a traditional level, to understand a program, to understand a certain size of things and a certain form of things. And, you know, what, you know, Boston Healthcare for the Homeless does is they have more of an immersion program, you know, process where we have to look at, right, like what do the patients and what do the people need, right? And then that really drives the thinking process, the operational process, the design process, if you will. And at the end of the day, the big picture of it, at least personally for me, for as an architect, is it's a program that's very much driven by empathy and by respect. So I hope that a lot more designers and architects get to touch programs like Boston Healthcare for the Homeless, and that's why it deserves, you know, a bigger audience, because, you know, as designers and as planners and as architects, it's like, you know, there's a need for us to grow the vocabulary of empathy in our design process. Hopefully that makes sense.
I think that's beautifully said, and I thank you for adding it. And, you know, one thing, you know, we might think about going forward is that, you know, Boston Healthcare for the Homeless program doesn't have the advantage of other large medical institutions in having on-staff planners and architects as a resource for sort of to troubleshoot immediate problems or to think very planfully about their long-term sort of needs and infrastructure. And it might be that there's a role for some group of architects, maybe MASS, but maybe MASS isn't the best thing. Maybe a larger group of associated perhaps with the folks who are involved with this committee, who can kind of have a kind of long-term commitment to BHCHP to support them in the ways that other large healthcare institutions are supported with the internal resources that they can afford.
That That is again very inspiring. The whole reason for this committee at the BSA was to raise awareness among architects. As an architect, there is none of this, not even in our schooling and education, internships, practice, mentoring at any level, and homelessness is one of them. And there are other aspects in our society where there is disadvantages for people who cannot receive the type of environment or live in an environment that we design every day, for, let's say, developers or for institutions who are fortunate with their funding, to this nonprofit funded organization. So not only in this typology, but in other typologies. So there are a group of us who are very much interested to help.